which is our CMS, Centers for Medicare and Medicaid Services demonstration project. It's one of the many projects funded out of the Innovation Center, and it was a specific call for proposals. It's the initiative to reduce avoidable hospitalizations of long-stay nursing facility residents. And we're one of 7 sites in the country who are participating in this 4-year initiative, and we're just over halfway through it at this point. We have partnered with 19 nursing homes in central Indiana, and the goal is to reduce avoidable hospitalizations. We have placed an RN in each of these nursing homes full-time, as well as half a dozen nurse practitioners who support these RNs, and then they are in turn supported by geriatricians on the project team like myself and other faculty members here. And with this project, we are working with the nursing facilities to implement a range of evidence-based tools and practices, as well as helping provide for some gaps in clinical care coverage in order to reduce hospitalizations for this very frail population. It's not an easy fix, and I was glad when I saw the call for proposals that CMS understood that this was not going to be an easy fix. We can't just do better medication reconciliation when someone comes back from a hospital and say we're done. It really needs this multi-component type of intervention. So we're doing it using a variety of strategies. We are focused on proactive chronic care management, so managing medications, dealing with polypharmacy, good chronic disease management to prevent exacerbations of heart failure and other diseases like that. Diabetes, good. We're helping support with good glucose monitoring, adjusting insulin regimens. So attention to chronic disease, also attention to recognizing acute change in status and how to react and deal with that appropriately and manage in place when possible, and it's often possible to do that. To do the primary way that we're doing that is implementing the Interact program. Interact is it's available online, interact2.net, and it's interventions to reduce acute care transfers. It's one of the few sets of quality improvement tools that were designed specifically for the nursing home to try to address this problem. It has communication tools that we're using where CNAs, CNAs are the frontline staff who provide 90% of the hands-on care of nursing home residents. So if they see a change in status, they use this tool to report it to a nurse who then can follow up with an assessment. It also has structured tools for the conversations that a nurse has with the doctor or nurse practitioner regarding a change in status. Many of these interactions occur over the phone. Doctors certainly are not in nursing homes full time. The system isn't really designed for that. And so when there is someone who's sick, having a structured way to communicate what's going on makes all the difference in the world with that interaction and with the confidence of the doctor on the other end of the phone and the nurse in the facility that together they can come up with a good plan to treat that person safely in place and continue to monitor them, or to transfer quickly to the hospital when that's appropriate. We are also very interested in palliative care. So attention to really good symptom management and advanced care planning. Advanced care planning is the cornerstone of our palliative care program within Optimistic. In Indiana, we have the POST form, Physician Orders for Scope of Treatment. It is the same program as this national POST program, which many states have adopted, which is a standardized way to state your wishes for care, your care preferences, and it certainly includes code status, but it goes much beyond CPR or no CPR to include if you would want aggressive care in an ICU, limited additional interventions, or if you'd want care focused on comfort and to remain in place if possible. It's not a do not hospitalize. If someone falls and fractures a hip and is in excruciating pain and we can't manage that in the nursing home, then we would still need to transfer that person. But if someone says that they want comfort care, or their healthcare representatives say that they want that for their loved one, when that person can't make their own decisions, then we need to honor that. And so through Optimistic, we are working closely with the nursing facilities and all the residents and their families to talk about advanced care planning and when appropriate and when the family and resident are interested to fill out these post forms. And we're finding that many of them are choosing comfort care, and then that pushes us to be able to provide that kind of care in place in the nursing home. So those are the main interventions to try to prevent an unnecessary hospital transfer. But when transfers do occur, we're also working around that transition both to the hospital and then when people come back to the nursing home to make sure that those transfers are as safe as possible.